Wow, you all do look fabulous. It's such a great honor and a privilege to be here, and I am just so impressed by the work that's done by the committee who put together this conference. It's one of the nicest I've attended over the years. Thank you so much for having me, Dr. Campbell, Dr. Alexander. Thank you so much. I'm told that there's not a lot of sickle cell disease in the Cayman Islands, but yet this talk was invited. Whatever the reason, I'm always happy to speak on sickle cell. So thank you again. You know, I'm a GP by profession, not an obstetrician, not a hematologist. So every aspect of sickle cell disease impressed me, hurt me many times. And one of the earliest things that used to hurt me deeply in my heart was young women with sickle cell getting pregnant 22 years ago, many years ago when I just started at the unit, and having really bad outcomes. It was terrible. As you can imagine, maternal morbidity and mortality, in the prime of your life when you're so expectedly, envisioning a beautiful family, and then something goes terribly wrong. It was devastating. So I think that brought me to doing some work looking at pregnancy in sickle cell. But today I want to focus not on just sickle cell, but other issues in the reproductive health of persons, of women with sickle cell disease. So just a couple of slides on the burden of sickle cell disease. Just as recent as 2009, the UN General Assembly at their 63rd session recognized that sickle cell anemia is indeed a public health problem. Currently, we don't have good figures, but we estimate about 7.74 million people are living with sickle cell disease in the world, and 5% of the world's population possibly carries a trait gene for a hemoglobin disorder. Annually, over 300,000 babies globally are born with a severe hemoglobinopathy, and over 75% of these births occur in sub-Saharan Africa. And where these babies are born depends, what the fate of these babies will be depends on where they are born. So much so that in sub-Saharan Africa, 50 to 90% of them will not see their 5th birthday. It's really quite devastating. It's the most common monogenic disorder worldwide. Monogenic means it's a single gene defect that causes so much potential devastation, and it's a multi-system disorder. And I think as a GP, that's what kept me going, because you can't predict what's going to come next with sickle cell disease. It can be quite severe, with multiple acute complications, such as painful crisis. Most of you would have heard of those. Acute chest syndrome, stroke. What is so devastating about stroke with sickle cell is that it occurs in children, Of course, in older adults as well, but childhood stroke is really terrible. And then it can also cause, as populations are living longer, it will cause progressive organ damage. If you look at the Caribbean region, I won't go through my first few bullet points, but the incidence of sickle cell disease is the 2nd highest in the Caribbean. And the prevalence of the S trait, the hemoglobin S trait, is about 10% in most of the territories of the Caribbean. This is a busy slide. This and the next slide are. And this is from the Global Burden of Disease study. These numbers were published in the Lancet Hematology in 2023. And I have highlighted with the yellow. What I really want you to see is that the birth incidence in 2021, as I said earlier, sub-Saharan Africa has the highest, and at 396 affected births per 100,000 live births, that is the number for the Caribbean. And my Jamaica, highlighted in blue, is actually second to no one else. It's not something I like the numbers in. Jamaica actually has it has the highest incidence in the Caribbean, but that may be, numbers are research numbers, may be dependent on various factors. But suffice it to say that Caribbean does have, indeed, the second highest burden of sickle cell disease in the world. So moving to reproductive health in sickle cell, as children with sickle cell disease are surviving longer, thankfully, there's a lot we can actually do to enable good health and longevity. Reproductive issues are taking center stage in their lives. You know what I mean? When I came to Sickle Cell Unit, as recent as that, we were so busy trying to just keep children alive and keep even adults alive. Not a lot of focus is there on, women wanting to have children and other reproductive health issues that young girls, adolescents, and young adult women will have. And we as healthcare professionals and communities, families and other people in the communities need to be prepared to guide, counsel, and manage the various issues they will have through their menarche and menstrual health, fertility, navigating having a disease and navigating fertility, issues of fertility preservation, contraception, pregnancy and childbearing, child rearing, including breastfeeding, etc. And then, of course, the other end, menopause and other gynecologic concerns. That's one of the first things I used to reach out to my gynae colleagues, and Dr. Campbell was one who paid a little bit of mind to what I used to harp on, that we need to examine these women with sickle cell disease. There's so much we don't know about their reproductive health, and we still don't. And this is global. I'm not just talking the Caribbean. But a couple of slides on each of these areas. Menstruation. Typically, there's delayed menarche, especially in the more severe types of sickle cell disease. In Jamaican studies, we have shown that menarche in the commonest, which is the SS genotype, homozygous sickle cell disease, menarche in our cohort study was at 15 to 16 years. It's about 2.5 to 3 years after. But they will have puberty. They will undergo puberty. What I say to my young girls is that, no matter what, you are all going to get breasts and have periods. They just look smaller than others, but they will grow and undergo puberty. And delay is more, as I said earlier, in the more severe genotypes. Menstruation can itself be a problem. It can be heavy, and it can come along with more severe dysmenorrhea, and it's important to differentiate between dysmenorrhea itself, which can be more severe, but it can also, the perimenstrual time period can also bring on an acute vaso-occlusive crisis. So as clinicians and nurses, we have to be aware so we can treat appropriately, because management will be a little bit different. And these are issues typically that your young patients will say are not addressed by doctors adequately. There are concerns about infertility or subfertility. We do know that the reproductive lifespan may be shortened. Number one, we said there's delayed menarche, and number two, there can be earlier ovarian loss. There were, in the 40s and 50s, there were early reports of infertility, and that might just be because there were early deaths, in sickle cell disease, so women may not have been living to have babies. In more recent studies, we have shown that the first pregnancy is about 4 years later than their matched AA controls, and this may be due to many reasons. Of course, the delayed menarche will lead you to have children later. There's delayed coitarchy, onset of sexual activity, and other social issues that can lead to that. Issues of fertility preservation are key. We said ovarian function decline occur sooner. And one of the earlier presenters said that, has told us or reminded us that women are having children later due to many other reasons. So this is a bigger concern in girls and women with sickle cell disease. We need to also look at what medications that girls and women are taking. So hydroxyurea and concerns around fertility with hydroxyurea, and of course there are newer disease-modifying therapies, and we wonder what the effects on fertility are going to be. So we need to be aware as practitioners. In the era, of course, of bone marrow transplantation and gene therapies and the use of gonadotoxic chemotherapies, we need to think of fertility preservation. And we do know that fertility preservation opportunities may be limited, especially in parts of the world where sickle cell disease is so prevalent. Contraception. There are many issues around contraception. There are a number of myths around fertility in sickle cell. When I joined the unit, a lot of women and mothers of or parents of girls with sickle cell thought, with sickle cell disease, you can't get pregnant. That alone is a huge problem, right? To get over the fact that you will get pregnant. And yet, contraceptive and reproductive choices counseling is suboptimal in a condition where it should really be optimized because pregnancy is such a high-risk event. There is also low interest in talking about contraceptive counseling among adolescents. These are all research studies. Contraceptive utilization is low. In our own studies in Jamaica, we have shown that teenagers with sickle cell disease are using contraception less than their match controls. So there are a number of issues around contraception. We also know anecdotally that healthcare professionals are kind of wary of providing contraception or contraceptives to girls and women with sickle cell disease because, again, there are myths. There are worries that progesterones and estrogens may be associated with many side effects, but suffice it to say that any contraception is safe to utilize once you have looked at other risk factors that may be there. So, for example, with OCPs, there's always a theoretical risk of thrombosis, and we know sickle cell disease can be a thrombogenic phenomenon. But really and truly, studies don't show much evidence of increased thrombosis. So look at the profile, assess and weigh the risk versus benefit of using hormonal contraceptives. Couple slides on pregnancy. So when we look at pregnancy outcomes, sickle cell disease will affect both maternal and fetal outcomes, and a few of the common ones are listed there. There's increased frequency of sickling. Pregnancy will predispose you to higher levels of sickling with all the all effects downstream, more infections, UTIs, pulmonary complications, acute chest syndromes, and possibly higher risk of preeclampsia. And for fetal complications, premature delivery and low birth weight that can lead to other problems such as perinatal mortality and maternal mortality. Perinatal mortality was really high in early reports. We don't see that more recent reports. We don't have that level of perinatal mortality, but we have to be cautious and look out for low birth weight and premature births. Maternal mortality, again, early in the 40s, women with sickle cell disease were told, don't even bother to have children, but we can't do that in today's day and age. We don't want to do that. As a sickle cell practitioner, I do not tell women that they should not have children. But you do need to work with them so that you can look at their clinical profile, assess the possible risk, because again, there's no clear prediction models to say which woman with sickle cell disease is going to have adverse outcomes. We have had women who don't have any complications. They're in their late 20s or early 30s. They've never had a painful crisis. They've not had to be hospitalized. And the first time they get in trouble is during their pregnancy or immediately at the end of their pregnancy. and this is where sickle cell disease is a little bit unique, that ending a pregnancy does not mean end of problems that are pregnancy-related. And there are women who have really bad sickle cell. They have recurrent pain events, etc., and yet they will breeze through a pregnancy. So it's difficult to predict who will have adverse outcomes, but we do have some ideas. So shared decision-making is very important in this. I'll skip a couple of the slides just to say that in Jamaica, though the direct maternal deaths are reducing, indirect death rates, maternal deaths are on the rise, and sickle cell disease, unfortunately, continues to be a contributor. We looked at two decades of work here and looked at maternal deaths, 1998 to 2007, and then this one looking at 20 years and comparing the 2 decades to see if there was any differences. And Dr. Campbell worked with us on this one. This is looking at national data sets. And we realized that we really hadn't made much of a difference or much of a decline in maternal deaths from sickle cell disease over these 2 time periods, even though the country had been undergoing quite a bit of work to reduce and improve maternal outcomes. So looking at this study in the second decade, we saw, if you compare sickle cell maternal deaths to non-sickle maternal deaths over this 10-year period, even though 2.8% of antenatal women have sickle cell disease, 10.8% of maternal deaths were occurring in women with sickle cell disease. There were no differences in access to health care or accessing antenatal services between these 2 groups, but all women with sickle cell who delivered were doing it directly under obstetric supervision. So that's something good, and most of them died in intensive care versus non-sickle deaths. 49% of deaths in women with sickle cell disease were due to complications of their sickle cell disease, and their maternal mortality ratio was 4 times higher than their non-sickle counterparts. There were no differences in other pregnancy outcomes, no difference in infant survival, and in a quarter of the women who died undelivered, only 35 to 40% succeeded in having a live infant. So what are some of the clinical problems we must be aware of in sickle pregnancy? Painful crisis, that is the hallmark of sickle cell disease. And in pregnancy as well, bone pain will increase, especially near the end of pregnancy and continue into the immediate postpartum period, because that's when the fetal hemoglobin levels in the woman tend to fall. Other complications that are quite significant, acute chest syndrome will increase or can increase. Some may begin as acute painful crisis and lead on to acute chest syndrome. Preeclampsia, for the most part, and most studies globally and in our setting, are we done? Preeclampsia does tend to be higher in women with sickle cell disease. Pregnancy-induced hypertension is probably not higher. But remember, sickle nephropathy is a reality, and because sickle cell is a genetic disorder, people as young as in their 20s can have nephropathy. So going into a pregnancy, a number of women may already have some amount of nephropathy, which you need to be familiar with and aware of, and so screening is important. Delivery, there's no greater indication for an operative delivery. I'll leave it as that. We do not think they need to have a C-section simply because they have sickle cell disease. And how do you manage a sickle pregnancy? The most important management point is this, that multidisciplinary care is required. Okay, so hopefully you can have access to a maternal-fetal specialist. You need to have coordinated care along with a sickle cell disease specialist, possibly have on board an internist as part of your team, to manage this woman who is planning a pregnancy and then goes through a pregnancy, and also the immediate postpartum period. So management begins from the preconception period, during pregnancy. We need to ensure they have all their vaccines going into pregnancy. There are some medications that they might have to come off. We are still, there's a lot of talk, and it's not just talk, it's not easy to decide whether you take them off the one disease-modifying treatment which we know improves sickle cell disease, and that is hydroxyurea. It's still up in air what a practitioner and a patient decide to do with coming off hydroxyurea through their pregnancy, and other drugs might need to be adjusted. Labor and delivery, be cautious that they do not go very close to the end, or definitely you don't want them to go post-dates, because placental insufficiency will occur, and so aim to deliver between 38 to 40 weeks, definitely. Have cross-matched blood available, have access to oxygen. Do not encourage them to have home deliveries and so on. Please encourage them to have, to deliver in hospital. And then postpartum care, bring them in a week after delivery, definitely, and review them, and be very, and counsel about looking out for an acute pain event, etc., because those can be critical. The last slide is this slide, which has very little written on it because we don't know much about it, right? Is it that we think women are going to die anyway, so we don't need to consider menopause? Well, that's not the point. And that's one of the reasons I'm looking at aging, because I do want to know. We just don't know enough about menopause. There's not many studies on it. They probably will have early menopause, and the gynecologists in the room, so many of you are women's health specialists, will understand what menopause does, but worse to have it early and what the impact may be on bone density. Can we use hormonal therapy in women with sickle cell disease? What's happening with cancers, breast cancer, cervical cancer, other gynecologic cancers? That's also an area that is under-investigated in sickle cell disease, not just female cancers, but any cancers at all. And what we don't know much about is sexual health, including dyspareunia. What we do know is that people with sickle cell disease will have a lot of pain syndromes. Is dyspareunia one of them? And do we just put all pain down to sickle cell pain and hence undermanage? So a lot of areas of investigation. So those of you in the room who might be inclined, please join us in understanding more on this area of reproductive health in sickle cell disease. That's the last slide. Thank you so much.